So I'll just go around and do some introductions, and then I've got a few things to show you by way of update, and then sort of opening up to discussion really with the group of where we are and where we're going to go to next. So if I just go around my screen, if I could start with Gordon.
Hi, I'm Gordon Ferns. I'm from Brighton, from University Hospitals, Sussex, and at the medical school, Brighton Medical School.
Thank you. Sam?
Hi, yeah, I'm Sam Bennett. I work for Sanofi. I'm the NHS Engagement Manager and supporting the AHSNs with things such as lipid optimisation.
Thank you. David?
Hello, I'm David. I'm the nurse consultant in cardiology at University Hospital Sussex, and I work the west side, so predominantly at Worthing Hospital.
Thank you. Lucy?
Hi everyone, I'm Lucy Galloway. I'm the pharmacy lead for the NHS South East Genomic Medicine Service Alliance.
Okay, nice to see you, Lucy. Helen?
Hi everyone, I'm Helen Garud. I lead the ICS Surrey Heartlands ICS CBD Medicines group. I have a very special interest in cardiovascular medicine, and really pleased to be on this group.
Thank you. Richard?
Hi, Richard Blakey. I'm GPSI in Cardiology in East Sussex and the CVD clinical lead for KSS AHSN.
Thank you. Pete?
So I'm Pete Green, I'm a GP, but I'm also involved with Heart UK as the chairman, CBD Prevent as the national benchmarking programme, and the Accelerated Access Collaborative on lipid management uptake.
Thanks, Pete. Andrew?
Yeah, I'm also a GP in West Kent, in Sevenoaks. I'm plan care lead for West Kent, CCG lead, but also co-diagnostic lead for Kent and Medway.
Thank you. Kate?
Hello, I'm Kate Shipman, chemical pathologist, also at University Hospital Sussex.
Thanks, Kate. Chong?
Hi, I'm a consultant endocrinologist at Ashford St Peters.
Thank you. Nagar?
Hi, I'm Negar Mahsoudi, consultant chemical pathologist, Surrey and Sussex.
Padmini?
Hi, I'm Padmini Mankat, the chemical pathologist at Durham Valley Hospital, Dartford.
Thank you. And I think that I've covered everyone. I'm Jen Bailey. I am work for Kent, Surrey and Sussex AHSN on the CVD programmes, covering lipids and FH as part of a national programme that all AHSNs around the country are working on. So good morning, everyone. Thanks for joining. So as I said, I haven't really got a sort of written down agenda, but there was a few things I just wanted to update on, and really pleased to see Pete on the call, because I'm sure that you can help support giving us a much needed updates. We run these meetings every 8 weeks, and they're for Kent, Surrey and Sussex. And we've got real representation in the group from all of our ICSs or from our areas. And what we've also done is in the southeast is team up with Oxford and Wessex AHSNs with KSS to develop more of a southeast approach to the Lipids and FH programme, but also the wider CVD, and sort of having those conversations with and being supported by the Southeast Clinical Network around their CVD programme, and how we all sort of support the systems in various ways, and be able to work together to do that. So obviously there is the sort of the wider Lipids and FH programme. The new NICE guidance came out recently. We circulated that. Obviously we're going through the booster programme, the priorities of COVID, and it was that sort of feeling of, inclisiran being there, and do we reach out, and where are we? And we connected with our various meds management leads across the patch, and talked to various colleagues of what should we do? And I think we had this call on the call last time, is the sort of running a Southeast webinar on lipids and FH, and looking at the various parts of the pathway, and sort of taking through an update for the Southeast, but also that sort of education element of how do we sort of support PCNs and practices moving through, and also now the new sort of prescribing and reimbursement around inclisiran and sitting in secondary care. So how do we sort of take that forward? So we've floated I'm interested to hear from the group, but we've floated an idea of running that webinar at the end of April. We felt that perhaps by then, sort of the priority of hypertension, and then the CVD DES coming back online, we felt that perhaps the end of, and also Easter holidays and Easter sort of really hampers April. So we were looking at the 27th of April between 9:30 and 12:30. I'd keen to hear from the group of whether you feel that is a good date to go for. Obviously very early days of just getting that date in the diary, and then thinking through how we deliver that, how we put that into a sort of Southeast update, but then also what elements are we going to be able to offer the education support. So just on that note, we get prescribing data every month from the national team around the lipids prescribing. So what we've done, I'm just going to share my screen briefly. And this again is the very start of, looking at, we've got our CBD Prevent audit data, and then we've got where we are with the prescribing data. So I'm just going to share my screen. And I think this is something that we could build on, but again, I just would really like to hear feedback from the group of whether this is going to be useful for systems, because what we've been doing is getting this on a monthly basis for each trust, or for CCGs, and then for secondary care around the prescribing of statins, ezetimibe and PCSK9s. So we've pulled that out, and what we've done just in the last week actually is add in the Southeast CCGs, as well as Kent, Surrey and Sussex CCGs. So this is looking at the high intensity statins, and if you hover over your various CCGs, it tells you at what rate the prescribing is, the performance versus target over time, and then a scatter graph on by year and by quarter. And then this is a sort of trend over time. So the top line is the number of statins prescribed, and if you hover over it, it gives you a number at every quarter. And then the bottom is the number of high intensity items that are prescribed, and again it gives you a trend timeline. This is a heat map around the statins use. So this is looking, you can filter this by AHSN. Let's filter it to Kent, Surrey and Sussex. And then you can it's broken down by PCN, and you can filter by CCG. Let's just do Kent and Medway, looking at every PCN and then looking at the prescribing. So again, it's broken down by quarter, so you can then look at how the prescribing is going. The range is between 20% and 67.9%. This is your ezetimibe. This is, again, I've filtered it now. Let's go back out of the filter. So this is looking at Kent, Surrey and Sussex areas of CCGs, and again your scatter graph at quarters. And this is how we've just broken down this type of prescribing. You've got a heat map again that can be broken down to PCN level of the prescribing over a trend time in quarters. So it goes from 2016-17 up to 2021. And then we've got PCSK9 looking at the performance, looking at the trust, the patients per quarter, the breakdown of the medicines, and then again the patients per quarter in a sort of timeline breakdown. So that's what we've got for now, and just keen to sort of open up and hear what you think. Gordon.
Thanks, Jen. So one of the issues, I suppose, is great data, and I'm trying to understand it's going to be difficult, I imagine, despite the fact there are graphical representations. But one question is in relation to what target means. I mean, target treatment with ezetimibe, for example, what does that actually mean? Is that, and obviously that's not, from what I can see, it's not related to LDL values. What is it related to?
Well, so I think, and Pete or Richard maybe could help me here, but I think that we are set trajectories of where we're supposed to be as an AHSN by the national team of where we're supposed to be with our prescribing of these specialist medicines, and we have expected prescribing outcomes over every quarter and then per year, and I think it's against that, but please help Richard and Pete. Pete, want to go?
I think Richard might be better than me first.
Richard.
Yeah, this was a bit of a presumption really, but I imagine that there is a sort of a national, that somebody's decided. I can't even remember in the NHS improvement, the system leaders forum, whether that sort of thing was discussed. It might have been. I don't remember the details.
Yeah, there are set trajectories.
Yeah, but I think we should question it because if a lot of our work is getting any of these things is going to be heading towards a target that we don't really understand and may not be clinically evident or would stand up with our peers if we were trying to argue about a strategy or a change of treatment based on something that had not very solid grounding. I think we need just to be really clear that that is the right thing to do. So yeah, I can sort of understand an expected percent number of ezetimibe prescriptions per area, but I don't know whether a target, it needs to be really clear what it means by a target. Yeah. I think it was interesting though, it looked like a converse or an inverse relationship between high intensity statins by PCT and ezetimibe. So which is interesting. So then ezetimibe looks like a bad, like an indicator of inferior treatment. So I think it's useful data, but actually whether we should be then referring to targets and things, I'm not really sure about that. But I think what we need to do is we all need to get the theory behind that and make sure that we agree. And might just have to change the wording from target to something else. If doesn't mean we get rid of it, but we use some other wording so we're not questioned in the future. Yeah,
I think that's a really good point, and it's for I think this data is for us to shape as this group. It's just what will work for us. Pete, do you want to come in?
Yeah, so I think what this data is showing is the number of prescriptions, and there's been some push centrally to sort of have some targets around that. So it's usage rather than treatment to target. As you'll know, the lipid management guidance that came out in December did have some lipid treatment targets in it. It's nice endorsed, and it's got a slight fudge in it, in that it's still 40% reduction and then it's got the lipid targets in it. And 40% reduction is almost impossible to calculate and monitor in, well, virtually any setting, but certainly in primary care, it just doesn't work, which is part of the reason why they've accepted the targets going forward. One of the things that we're looking to do in CBD Prevent, which won't be in the next reports, but should be in the report after that, is looking at those patients on secondary prevention who are treated to target using those thresholds from it. There's a lot of work going on nationally supporting the lipid management pathway, both in terms of sort of education and resources that are all being collated together at the moment. And as soon as we've got that into a cohesive form, I'll be able to share all that information with you. So, it covers from a primary care perspective, who we should be looking at, what your options are, patient support tools so that you can help have those conversations with patients about what the relevant pros and cons of the different medications may be. Advice and guidance. We're looking at whether advice and guidance needs to be set up for some of these areas, perhaps even on a national level, because we know, for instance, in East Kent, currently there isn't a service at all for it, which has become almost a barrier to them adopting the lipid management pathway, because I think it will raise more concerns than resolve issues. I mean, my view very much is it just enables primary care to do that much more. And we should sort of get on with it from there. So there is a lot of resource and stuff that's coming through. So, and this issue of target is, I think it was a big step forward for NICE, to be fair, to agree to have some numbers within that lipid management guidance. And going forward, we will be able to start looking at those. And I think that things like the UCL Partners tools that Matt Keeney produces, which can run in EMIS, so across, I think, all of the practice we've got in the Southeast, they will start to incorporate some of those numbers and metrics into their reports going forward. So again, we can identify the patients who are suboptimally treated and then think about, what we might like to do to optimize their treatment, obviously discussing with the patient.
Thanks, Pete. That's really helpful. Helen?
Thanks, Jen. Thanks, Pete. That's fantastic. Can I just cheekily ask, any idea, ballpark, when that package of information would be available to clinicians at all?
As soon as we can get it. So we're having fortnightly meetings at the minute. There's an awful lot of good stuff out there at the moment. And I think what we're trying to do is to sort of collate everything that's there, get agreement from the relevant people who've put together various bits so far that it can be shared and disseminated, and then get that out. There will inevitably be, one or two gaps in things that we'd like that aren't there in that first iteration. So we're not trying to get it to perfect before, we're trying to get it to be good enough and share, but then recognise where there are gaps that will work on filling those gaps. And it's things like, if you're going to do advice and guidance, you want a performer from primary care to collate the information so that it comes through in a systematic way to secondary care. The form's familiar, you can scan it very quickly, you can then provide your advice from it. So it's trying to sort of automate and simplify the various steps in the process as much as we possibly can.
That will be really helpful, and I very much look forward to seeing that come through.
Yeah.
Thank you.
Can I just ask then about that sort of advice and guidance? Because Andrew and Supriya and Padmini, we did that work on getting a referral form for around the lipids. So I did send that to Sanjay and Ian and Ken to try and progress that. But the feedback was that we had to do a whole load more work in terms of IT to be able to embed it into EMIS and to be able to have it populate, etc. So is that something, Pete, that in part of this pack is going to be something that we could pick off the shelf to use as a referral?
I think that there are two elements to that. There's what information we would want in the form, and how we want it presented, which ideally you want it to be, the same, pretty much across the country. Just makes life easier for everybody. There are then some slight technical bits in terms of, lots of different systems. I mean, we use DXS, I think, mostly in Kent, but there are lots of different systems that are added in as the interface between the core GPIT system that you might then use to produce these sort of forms that then get added into the ERS, the referral advice and guidance. So we just need to work through that. But there are probably half a dozen. There are thousands of these. So once you've done it once for a system, it can then be sort of shared and imported.
Okay, so I think it was through Doris or something. He was saying some system that we needed to put. But anyway, do you think it's worth us continuing down this road, or should we wait? for a generic one?
Hold for a short period. I would say. I would hope that if I hadn't fed back within the next month, we might need to, because it's like all of these things, they're great ideas, and then all of a sudden it hits some sort of barrier that nobody seems to be able to work their way through, and it all comes back to you need a local solution. But doing it once nationally would be far better, in my view, than doing it many times locally.
Okay, Andrew.
Yeah, I was going to add. I mean, inside EMIS, it's very straightforward. But if people use other methods for generating referral letters, then it adds complexity. But I hadn't heard that there was this ongoing discussion, Pete, over the last month or two. I've not been involved in that, in spite of being part of the kind of, I thought, core group for the referral form.
Yeah, I apologize. That was my fault, Andrew, because I wrote to Sanjay when we'd sort of sorted it out with our little group, and that was the feedback I had. And then it was supposed to go to IT, and I had to jump through all these hoops, and then it all just got very complicated. So apologies for not feeding. That's my fault. I didn't feed it back.
I think perhaps if you copy Andrew and myself into that, we might have a little think about what we can do to facilitate it moving forward.
Okay, perfect. I'll pick that up again with Ian, because it kind of got lost also, obviously, because of COVID and that response. Padmini.
Okay.
Thank you. It's just a comment with regards to the advice and guidance which Pete is working on. We do get quite a few of advice and guidance. I think, as you said, it should be streamlined and they should have a template. What I end up doing is asking them whether they have ruled out any secondary causes. I have to go through the whole lot and give them the advice, and in assuming for so many things. So it's better to have it in the advice and guidance form, that all these have been looked into and this is what it is, rather than we questioning that and then we don't know whether that is the case.
Yeah, no, I agree, and I think that the form Andrew designed pretty much covered off most of that. I mean, advice and guidance is advice and guidance. We're not asking a consultant to, contact the patient and ask lots of further questions, but you shouldn't need to come back to the GP and ask lots of further questions. They should have provided, it's a bit like, see and do the needful. It's useless. We've got to provide some information for you to give us some guidance back on. So if we're not giving you the stuff, you won't be able to do it.
Yep.
Yeah, sometimes we feel that it's better to see the patient rather than going up and down with this,
Yeah, but we one of the things that I think we're very aware of is the clinics are all busy, and so the more we can upskill primary care to have the confidence to manage patients and do things in primary care, the less pressure comes on the clinic from it. Equally, the more patients, now that it looks as though there's agreement for PCSK9s to be prescribed in primary care, subject to various paperwork and that behind the scenes, and again for inclisiran to be used in secondary care. But it looks as though, again, for those patients, wherever they're initiated, if the ongoing management can be passed back to primary care, with guidance, again, that eases the workload on the clinics, and gets the patient a better deal.
Thank you.
Thank you. So obviously that information will be shared, but that's also something, and we could bring in the pack that you mentioned around into the Southeast webinar. And if colleagues on the group do you think the 27th of April sounds?
Just one thing on the 27th. I know there is another lipid meeting on that morning, so I wonder whether moving to the week before or the week after. But subject to people checking diaries.
Yeah.
I mean, it wouldn't be the end of the world, but
is it a national meeting?
It's a national meeting being supported by one of the pharma companies.
Okay. Okie dokie. We're probably, so do you think that pushing into May is, or do you think that we should try for April still?
I mean, looking at, as far as I'm aware, a week either side would be fine. Okay. So if that works with other people.
Okay. So in terms of the dashboard for the group, that sort of, we've just started it. We haven't, it is on a Tableau system. It is really just, I suppose, for us to be able to take some time of who's interested to have a little look at that and pull out some of the messages, or see how that fits with the CBD Prevent data. I think there's just an opportunity there to build on it and to use it for our local systems to be able to just inform where we are with these prescribings. And then as we go through the different, we're also going to sort of add the formularies of whether that is a green on the formulary and what the picture of our region looks like.
I think all the formularies need to be, you know, in my view, the lipid management pathway is nice endorsed. You know, we need to get these formularies approved, you know, across the region, because it's an enabler. It doesn't mean people have to prescribe anything, but unless you've got that step, it becomes a barrier, you know, which just adds to the difficulty of it. So I really think we've got to get those prescribing agreements in place.
I think there's the other sort of layer around that of, it's one thing having the formularies, but then it is also around getting the guidance, or the nice guidance passed through your different areas. So I have heard for Kent that's going to happen at the beginning of April, in terms of that sort of nice being passed through. So they may well be green on the formulary, but then I think there's also the sort of layers around the prescribing and the challenges and the FAQs that we need to support practices and secondary care now to know. So in inclisiran, for instance, and I will share with the group afterwards, is a new sort of that secondary care are now going to be reimbursed for purchasing inclisiran, and that is, you know, so that it is available if they want to prescribe it, and then follow up in primary care, or, you know, how that's going to work. But that's quite new, and I think that there's many layers and FAQs to that. So
in terms of, I'll bring in Andrew in a moment, Sarah. In terms of FAQs, that's one of the things that we're trying to put together as part of that national list of things. We're focusing very much on the lipid management pathway, the NICE endorsed lipid management pathway. So inclisiran is part of that pathway, and clearly as a new drug, there needs to be some education, there needs to be some advice as to how to give it, who might be suitable. And, you know, the fact there isn't outcome data as it's a new drug, you know, what the, you know, the patient decision support is all there for. But the push is not really about inclisiran, it's about lipid optimization and using the tools that are available to us. And for most patients, that's up titrating and managing their statins. So it's very much around the pathway side of things, but yeah.
Absolutely, and where it fits in the pathway. But I think that there's just, you know, there's many layers of well, how do we get that? And then if they gave a patient a prescription, there is also challenges around where do they then get the prescription and what pharmacies are.
Yeah, so I mean, so secondary care, it will be on the Blue Tech form, and it will be, because it's a nationally approved drug, there will be one nationally approved form rather than each system having to develop it. In primary care, you can order you can order inclisiran from your wholesaler. I think it costs £45 and you get reimbursed. You claim it by an FP34D for £55. You know, so there is a process for doing it, and then nationally they settle off all the, you know, differences in, the overall cost. But it was very much felt that there needed to be some sort of token cost recognised at the primary and secondary care level, just so that people sort of didn't get loads of it and just store it. If it costs you nothing, you just go buy a bundle and put it on the shelf.
Andrew.
Yeah, I was just going to say, you mentioned about the Kenton Medway formulary. I don't think Fuad is on the call, and
no, he's not.
And I think Pete had a word with him, or was going to have a word with him about the kind of formulary issue, but maybe.
Yeah, so I spoke to. Sorry, I spoke to him on Friday. I mean, I know there are other parts of the country which have had the pathway approved, and I said I was quite happy to sort of ask and share, other people's application if that was useful to him. I've not heard back at the moment, so I think we just need to provide, whatever support he needs in that. I think part of his concern was there wasn't, a lipid service for East Kent, and that pushing through the pathway would drive up demand and therefore create problems for patients rather than solve problems. But yeah, we just need to keep on the case with that.
Thank you. Yeah, I'm meeting with Fuad soon, I hope. So
yeah, okay.
I'll just get some of that updated, just so we've got a clear sort of vision of where we're all at and the sort of timeline of it. Helen. Oh, sorry.
Thanks, Jen and Pete. Just to ask about parity of accessibility and provision of inclisiran to primary and secondary care. Is it going to be the same in terms of financial cost across both sectors?
My understanding is yes.
So yeah. Okay, great. So I'm looking forward to seeing that information. That'd be fantastic.
I've got some really helpful information that's just come out about it with a helpful FAQ sheet. So I'll share that after the meeting, Helen.
That's brilliant.
Alison.
Yeah, it'd be interesting to see the prices because they were very different initially. So what we've said at the moment is only for primary care. We're only going to recommend it. But actually in secondary care and lipid clinic, we don't have any facility really to administer it. So I guess we need to think about that.
So the update was that from January 1st, there's been a change to how inclisiran is reimbursed in secondary care, as trusts will now be reimbursed by NHSE when ordering inclisiran. And then we've got so it is aligned, and it is also around not necessarily holding it in secondary care, but if the way that it stood with only primary care being able to order it, it meant that if it was initiated in or if a patient was seen in secondary care, they didn't have the ability to access it if they wanted to. So it was part of that making sure that they could then be supported by education or that pathway across organisations.
So will the trust be able to buy it for £45? Is that what you're saying?
Yes.
Okay.
Tony.
Thanks. Sorry for being late. I just come from the equivalent meeting for South East London. Just to sort of put this in, one of the ideas that has been discussed in South East South West London has been community pharmacy-led cardiovascular and lipid services as a way of managing, shall we say, long-term adherence, managing lists, etc. One of the models that has been proposed that I think many on this call might be familiar with is the denosumab model that's already used in management of osteoporosis. And that might be a sort of pathway that already exists that can just rapidly be repurposed for the initiation and management of inclisiran in terms of both administration, monitoring, and adherence checking.
Oh, well, that's interesting, Tony. I'm not familiar with it. Would you be able to share that?
I'll try and get a hold of I'll get hold of it of one of my SPRs because we do it in Bone Clinic. But that might be one that might be one that sort of can actually work between primary care, that's shared primary care and secondary care, where we put a community clinic in that, you know, it could fit anywhere along that pathway as well. I'll send that over.
Thank you. Andrew.
Yeah, in Kent Medway, we have a denosumab shared care pathway, which is part of our primary care quality scheme, PCQS. So that may be slightly different from what you're saying, Tony, because this is a primary care pathway.
Yeah,
care.
It's probably pretty similar. It's just got a secondary care element in and just tacked onto it, but it's essentially I think, yeah, because we manage a lot of patients from that area up at GSTT, so we're familiar with that, with the pathway that you've got.
I think in terms of some of those resources, sort of both education, patient support and clinical support I was talking about earlier, one of the things that we're quite keen to do is make sure all the resources are in place, but not tell local areas how to organise themselves locally, because some it will be more through, you know, directly back to primary care, some it will be through the intermediary clinics, and even if the delivery of the medications in primary care, there's still the advice and the guidance, and does that need to go straight to a consultant, or can we have some intermediary service? And I think, you know, different parts of the region, but different parts of the country are doing this in slightly different ways. So I don't think sort of in the national scheme we're trying to say this is how you must do it. It must work for a patient, and so the local areas must have something that sort of, you know, meets all those elements.
Alison?
So yeah, sorry Tony, I was just interested in what you said. So we have a denosumab pathway, but it's primary care. But were you suggesting that the community pharmacies are administering the denosumab? I thought you said community pharmacy.
We could actually repurpose the lipid version to do the community pharmacy. Say that the pathway, who actually does it, you know, we can have a variety of people doing it. So it's effectively a shared care model for denosumab between secondary care and primary care. How we do that and which part who does exactly what, we can vary. The thing is that the template already exists for another drug.
Yeah. So what you're saying at the moment is that potentially that inclisiran could be given in a commissioned community pharmacy service.
If that is what you wish to do, yes, it would be one of the ways of doing it.
Okay.
Thank you. Helen?
Apart from the discussions we're having here, a repository for shared practice on inclisiran so far? I know it's very new. I know we're less than 6 months, but anyone know of somewhere where people have actually collated all these stories and information and how they, so that we can share them and look at them, because that would be so valuable.
So the national team, that's on my virtual agenda, you see, Helen. The national team for Lipids and the HSNs have put, or they've already got a futures platform, but it's quite busy, so they're just at the moment pulling it out to be a Lipids and FH specific, because at the moment it's the AAC, RUP and Lipids, and it's all busy with and hard to navigate, so that's being pulled out into one platform, and very happy to invite the group to join that.
We're also looking at hosting all of that information, as well as all the patient information, on the Heart UK website. So we're trying to get a common story and make it as available as possible for that. I mean, you might tweak things due to your local service or the way things are delivered locally, but you know, the pathways, the guidance, the advice, the decision support tools, you know, shouldn't really need to be adapted. It's how you utilize them that's adapted.
Yeah, and also just to say that there's going to be a new Southeast CVD futures platform that's going to be run by the clinical network for CVD, and part of that will be lipids. So I'll be pulling sort of the things or linking to the Heart UK, or being able to just share that information so that it's easily accessible. Andrew?
Yeah, I just wanted to come back and point out that a lot of pharmacists are now embedded in primary care, and they have access to the clinical records, and they have access to the results, of course, and letters. And I would have thought the embedded pharmacists in primary care would be a far preferable route to community pharmacists who wouldn't have access to any of that. And also there's the issue about who's going to do the injection and what training they actually have to have completed before they actually do the injections. Because normally, if it's not a GP doing it, then there has to be some kind of protocol for clinical governance to ensure that's safe. Yeah.
Yeah, and I think some of the challenge, thinking about the BP or the community pharmacy BP program, obviously that's taken a bit of a knock because of COVID as well. But, that is now embedding. Pharmacies are joining that. But, again, it becomes quite complicated when systems don't talk to each other. And at the moment in our area, that's already a manual sort of nhs.net email going back and forth, and it's not even on pharma outcomes. And I think there's some learning to be done there, though, of sort of having that shared care approach. Is how can we learn from implementing BP, and then how do we include that sort of more CVD approach? Just wanted to touch on the sort of pharmacy element in primary care in practices. So we've got that small group of nurses and pharmacists that are working with Alison, Richard and I around that we funded for the FH course, and then we've developed that FH toolkit. So we have actually shared with the group recently, obviously knowing about the pressures of COVID and primary care and their capacity, but to run those searches by the end of March and have those patients reviewed and return that data to us. So it's just a little sort of glimpse, I suppose, of those patients, but just very mindful from what we've heard from that group, when we've heard from that group, because they're very busy, is also the sort of priorities that the PCNs have that may take them away from CVD into other areas, or and then actually who is there for CVD. So I think that there's some more work or understanding to be done around what capacity have we got in our systems to be able to sort of focus on this, and maybe the levers of Des and the other levers that are there as we move into April and the pressures aren't so much, it may change our landscape. But I just wanted to sort of update of that, because the capacity obviously is really harsh at the moment. Pete.
So I just wondered if I could talk a little bit about the CBD Prevent audit and familial hypercholesterolemia. So as most people know, cholesterol coding and familial hypercholesterolemia coding in primary care using SNOMED is not brilliant. So Steve Humphreys and I are doing some work with SNOMED to try and tidy up some of these codes, get some codes for some of the genetic variants that are detected, so that we've got a better cut for what's clinically familial hypercholesterolemia and what's genetically familial hypercholesterolemia. It's proving rather more complicated than certainly I hoped it was, but we're working through that. So that's just a bit of background around. Based on the figures that we've got for clinical FH from the CBD Prevent audit first time, and accepting that not all those patients may have familial hypercholesterolemia, but if you reviewed them, referred 65%, and 20% of those turned out to have a genetic cause, you'd hit the long-term plan target of 25% diagnosis based on 1 in 500 within the next 2 years. So I think, my personal view is that's the cohort to look at first, those people who've already had a clinical diagnosis, review them, see if they meet the criteria. If they meet the criteria, refer them through. So, you know, there's lots of other bits, but that's a sort of core bit to work on fairly quickly for that. In the second report, which will be out in hopefully sort of 2-3 months, we'll also be reporting on people who've got high lipid levels which could meet the threshold for FH, who've not been assessed against Simon Broom or Dutch Lipid Clinic Network scores, and suggesting that that cohort of patients get reviewed for people. Again, it will just be a number in the report. We're also looking at people with a Q risk of 10 to 20% and over 20%, and percentage of those on statins, just as a sort of headline thing. We're not, you know, everything's down to an individual patient at a practice and clinical level. So we're not suggesting every single patient should have something, but it should be thought about. And as I mentioned earlier, in the third report, which probably won't be out until the sort of tail end of this year, we'll be looking to get some figures on treatment to target for secondary prevention in terms of lipids, because I think that, you know, what we're doing at the minute is we're monitoring the number of prescriptions of the different types of medication used. What's more important is, you know, have we achieved the goals of lipid optimization for this cohort of patients, or as close as we can get it. One of the things we're also looking at, and there are some technical bits around this again that are slightly more difficult than I'd hoped, is we're trying to see whether we can demonstrate some of the performance against as a bell curve, because it's not just below target's okay, above target's not okay. It's the closer you can get that bell curve of the totality of those patients towards the target or below the target that's important as well. So just a heads up on some of the things we're working on.
Thanks, Pete. So the next report is going to be out when, did you say? Is it in the spring?
Should be spring, yeah.
Spring, summer. And then the next one will be the tail end of the year. So also just to say to the group that we are in Kent, Surrey and Sussex, one of the pilot sites working with NHS benchmarking, Pete, and the CBD Prevent audit. So Cheshire and Merseyside are one of the sites, and Kent, Surrey and Sussex. So, you know, again, we're at the early stages because, again, everything was paused because of COVID response. But we sort of have got that opportunity to, you know, bring, you know, get that support and really get into some understanding of what does that data mean for our area, what are the key messages, how do we then pull this prescribing data into, you know, what do we do to take this forward, and we'll have the support of NHS benchmarking in terms of, you know, that sort of pilot site approach and shared learning to take that forward.
I think the key to this is that things like CBD Prevent will highlight to practices and PCNs where to look, you know, where their performance relative to somebody else might be, you know, further to drift. So, you know, where to look first to get the most gain. You know, we're very aware that people are, you know, busy, tired, pressured, you know, so this is very much about helping you do the job, not there's a bigger job or there's a new job to do. And then it's using tools like the UCL partners tools to be able to find those individuals who will benefit. So, you know, we might be able to say, you know, your practice looks as though there's, you know, 2%, which is 200 patients or something, but actually the UCL partners tools can tell you the names of those 2%, and that's the bit that then makes it really, you know, much more easy.
Absolutely. And then sort of on a population health level of how we sort of pull that, what does that mean for us as an or you as an ICS, and then really starting to get into that CVD sort of segmented data around what is our population and how could you drill into, or what do we know about the health inequality sort of piece aligning with the CVD in terms of bringing back those key messages, because I think that, you know, in terms of sort of drilling down, that's going to be really helpful, isn't it?
And in terms of the inequalities, that's even more complicated to some extent, because when we took the first CVD data extraction, although we took over 1 billion bits of data, we didn't take the whole practice database. So we've needed to do some modelling for deprivation, because clearly people in the most deprived areas tend to be younger. And therefore things like hypertension will have a slightly lower prevalence in a younger age group. So they've done some modelling against that. But some of the performance in primary care doesn't seem to be as bad for variation against deprivation or variation against ethnicity as the poorer outcomes might have suggested. There was a sort of a narrative that, you know, people in the most deprived areas either didn't attend or didn't get picked up or didn't get managed as well. And some of the data in the first report does seem to put some question marks against that. Now, clearly the outcomes for these patients are still poor. So, you know, we need to just sort of work through that and think on that. Having said that, there's a gap of ethnicity data of about 18%. So that's a big sort of, you know, caveat on it, on anything around the ethnicity components of it. And in the third audit, we will be able to, I think, get the whole practice profile. So we won't be needed to do this modelling to come up with the comparisons. We will be able to do it on the real data.
And then there's also that bit, I suppose, around the people that aren't registered with a GP. You know, that's quite a proportion, isn't it?
Nationally, they think it's probably less than 1%, but you know, you're absolutely right. You know, CCGs have a responsibility, and you know, the ICB is going for looking after those patients, even if they're not registered. So, you know, how do you, and some of those people have reasons, inverted commas, for choosing not to be registered. But that doesn't necessarily mean the NHS hasn't still got a responsibility for providing healthcare to them. It gets complicated because we need to provide primary care and A&E care, but we don't necessarily need to provide secondary care. So it does get quite complicated.
Yeah, and do you think that 1%, do you think that since COVID that well, I know that there's been an increase in people registering, so do you think that has changed, or was that 1% before COVID?
I don't know, and I think that, I mean, I say 1%, there's a degree of best guess around this. I'm not an expert in this area, so there's a feeling that some people, that the GP list, I think, tends to overestimate the size of the population compared to other studies. And it's thought this is due to people being registered more than once, although if they're registered with their NHS number, that shouldn't happen. So I don't know the answer to that.
Okay. I was just thinking, you know, in terms of inequality, it's just kind of interesting, isn't it? And as you say, complex, but I'm keen to hear it. So we've only got a few minutes left, but I just wondered, Tony, Lucy, do you want to come in at all?
Unless you want, do you want a brief update on FH? Because I can do it in about a minute.
Yes, please. Yes, please.
Okay. People probably mentioned a lot of this, which is that there's a lot of education work for primary care, professions allied to medicine, etc., going on. That is currently in the process of going live on the RCGP website and also hosted on the Genomics England Education website. That is free access to all. Steve Humphreys and I and Dermot are working on a second module after the FH genetic testing module on an FH management set of modules. So it's going to be a 6-lecture series that we will aim to finish by the summer. In terms of training courses, the University of Northumbria course that quite a number of people did from KSS, the full 30-hour course is going to run again, but the aim is at the moment to use those people as primary champions with an extensive knowledge base, but also to bring in a sort of quick and dirty short course involving 6 hours of accredited learning to cover testing and diagnosis. First expressions of interest for that have already gone out there, aiming to run a course in April. Very unsure on the numbers, very unsure at the moment on the exact curriculum because it hasn't come back from Judith, GP in Bradford, who's the GP lead for genetics, but we will be running it. I've already secured a few places across the southeast region, but most of the places I think will be later in the year. So that will be literally for practice pharmacists or practice nurses who wish to help doing FH testing within their sort of, once you've actually cleaned up your lists, to actually do it locally. And then probably that will involve genetic testing. We have a lot of issues to sort out around, so that leads me into the second issue. That's consent for genetic testing. There are a variety of policies out there between CCGs, hospitals, British Genetic Society about who can actually take consent for these tests. We're trying to get some GLH clarification on this. So there'll be one policy that applies to all. Once that's in place, then hopefully it will not require either a secondary care clinic to do all of the testing, but primary care with an interest or appropriately qualified pharmacists or nurses could actually do local testing. So that's in line with the national priority for delivering primary care-based screening for FH. Nurse job description.
Can I just ask there, would that be of benefit then to our pharmacists and nurses that have attended?
Yes. The
course,
idea is that they have actually got the
this
accreditation. Yeah, and they will be able to pick it up once we actually get just a little bit of paperwork sorted out on who and what.
Okay, so Lucy and Alison, can we pick that up offline then of how we go about getting that information to share with the group?
Yeah.
Thank you.
So they'd have to have some sort of accreditation then. So
yeah,
because some of them have done the course, but they haven't actually done the competency. So we'd have to think about that as well.
Yeah. So it's just completing those elements. Yeah, exactly.
That's really helpful.
And then there's an element about consent that we just need to sort of just clarify and get a sign off on. Third aspect, nurses to do cascade screening. The bid is going in at the end of the week for South East England to add 2 extra nurses. So we're not going to go in 1, we'll have 3. And as people know, my original intention was always there would be 1 Southeast, 1 Southwest and 1 KSS as a start to help with cascade screening using a postal model. We will hear back from NHS England, we are told, within about 6 weeks as to whether those bids are going to be acceptable. Another bid that's gone in is to automate or semi-automate pedigree gathering. That is using an app already used at St George's for cancer genetics called FHQS. We have drafted all the necessary bits to build an FH application there, so that means that nurses or whoever's doing the cascade screening could then basically upload basically a pre-filled, pre-consented group of patients into the software they use, whether that's PASS or whether that's another, so that they could then actually run the cascade screening. It would just take out a lot of telephone calls and a lot of and a lot of issue and a lot of sort of routine process, and free the nurses' time up to do testing and doing discussions with patients. So that's also gone to a bid to NHS England. I have a meeting on it this afternoon to firm up, because there is a national informatics strategy that they have actually brought in. So we have to get it to align with the national genetics informatics strategy.
Oh, wow.
So they want one solution for the country, basically. So, and this might align with other things that people have heard of, like phenotypes, which is being used in East Anglia, but actually has substantial extra costs because they want a registration fee per user, and Famgenics, which is another, again, fee per user, which in the financial circumstances we find ourselves in are not of the preferred options. So we'll hear about that towards the end of the year. So that's where we are with nurses. That's where we are with cascade screening JDs. Apart from that, all the request I would make is to sort of local clinic leads. Can you start putting together lists of people that you have with genetically diagnosed FH, please? And put them on a spreadsheet so that when we have these people in post, we can start work on the list later in the year.
Okay, so is that something that we could help with, or sort of I could help with?
Yeah, so sort of the major
be...
clinics, sort of, you know, Brighton, Hastings, Maidstone, Surrey, you know. And
then just sort of run the list and then have them at the ready.
Yeah, it's just really asking the clinicians just to start putting together the lists, or remembering to sort of, you know, if they have the hospital IT that can extract this data, great. Otherwise, I'm afraid it's got to be done the hard way with making up your own spreadsheet, unfortunately.
Okay, and so Kate, can I just come in to you and ask, you know, is that something that you would go, oh yes, and Padmini, that's easy, or is that something that you would need some help with?
We got an A-level student over the summer to start, so we're almost there, but I'm going to have to do the rest. Yeah, and it's a bit manual because we don't record the results on the IT system, so they don't actually say if it's a positive or negative. So I can tell you how many FHs we did electronically, but not what the results were. Damn it. Yeah.
Common problem.
Yeah.
Padmini?
Yeah, Jen, as you know, I don't have any help here. Any help which you can provide, I'll happily take it.
Okay. So, and in terms of sort of running those searches, would that also then require a spreadsheet to be able to pull what fields you want, or is that something that you've done then already? You've prepared what you're pulling in terms of a spreadsheet.
And we keep every single report in a folder. So we basically just gave them a folder and told them to type it in. Yeah.
I would like to do it. I would like to do it for you through the genetic laboratory hub, but they are basically having a mental breakdown about the supplying data in 20 different directions at the moment for a variety of programs. So I have not got far, however nicely I have asked. So that's why I'm having to come to you.
No problems.
It's so good to see the NHS has moved on from quills and inkwells.
Yeah.
Dangerous new technology, Pete. You know, where's your stylus and piece of clay?
Yes.
And Nagar, how do you feel? How do you feel?
Hi. Yes, I'm more or less the same as Kate. I keep a record of all the genetic testing I've done. Some cases diagnosis have been made clinically. I've also got a record of them. So not too difficult for me to collate data on a spreadsheet.
Okay. Cool. Okay. Well, we're over time, but not too bad. So thank you all for coming. I'll write a summary of little notes, circulate to the group, and I'll circulate the information that we've sort of talked about the inclisiran and the pathways and the opportunities. So thank you ever so much, and I'll see you again soon.
Thanks.
Bye-bye.
Thank you.